I would go on to the next speaker. It's my privilege to introduce Dr. Dinesh TALWAR sir, my mentor and teacher. He requires no introduction, an astute clinician, and nobody can analyze clinical studies like he does. Over to you, Dr. Dinesh TALWAR sir, for a talk on CNVM.
Thank you, Dr. Raju. Now, we'll now come to the last talk of the day, which is on age-related macular degeneration, exudative type. This is my financial disclosure. Let's start with a case. This is a patient who presented with an occult CNVM with SRF and was treated with PRN ranibizumab, was requiring injections every 6 weeks and was therefore shifted to aflibercept, hoping that we would need less injections. With aflibercept, we were able to bring him to 10-week injections. We tried twice to increase the duration to 12 weeks each time the recurrence occurred. So finally, we realized that this patient can only be extended up to 10 weeks with aflibercept. This is a second patient who we started with aflibercept as the initial treatment. And you can see that every 4 to 6 weeks after the loading dose, the patient was requiring injections. So sometimes aflibercept also may not respond to the initial loading doses. And in these cases, then the patient is maintained as a stable lesion on treat and extend to the maximum that we can. So this patient was maintained on 6 weekly injections. This is the third patient who was followed up for 6 years, initially started with ranibizumab, was not responding well, was shifted to Eylea, who did not respond, went back to ranibizumab, and finally was then shifted to Eylea in the end again. And when the second time when he was shifted to Eylea, we were able to extend the duration from initial 4 weeks to 8 weeks, but then he regressed to 6 weeks, again improved slowly to 10 weeks, and finally to 16 weeks. So this 16-week extension, it's important to remember, does not reach in a one straight line. There are ups and downs, it's a zigzag course, and you should not lose heart if that happens. The other important thing is that after you've reached 16 weekly extension, and you've been able to maintain that twice in a lesion which is dry, you can actually possibly consider stopping treatment and only following up this patient. This is another patient where 12 weekly extensions were, 12 weekly treat and extend was continuing, and despite that you can see this large RPE detachment developed, and we had to bring him back to 8 weekly treat and extend. 8 weekly injections of Eylea. How do we approach an individual patient? So the usual approach should be you give 3 injections. You could be giving bevacizumab, ranibizumab, or aflibercept, whatever you use. Assess at month 3. If the lesion is dry, you have 2 approaches. You can either take him to a treat and extend approach, where you extend the intervals between the injections from by 2 weeks or by 4 weeks up to a maximum of 12 weeks if you're using ranibizumab, or 16 weeks if you're using aflibercept. Alternatively, you can maintain this patient on a PRN treatment, which is cheaper, at least for our patients. So let's see, you have a patient, 3 months he's dry, after 3 injections he's dry. Now follow this up for another 3 months. If he stays dry for another 3 months, now you can increase the interval between his follow-ups. He's not getting any treatment, but his interval between the follow-ups can increase progressively to 6 weeks, 8 weeks, 10 weeks, to a maximum of 12 weekly. 12 weekly follow-up in ARMD, exudative ARMD patients will continue more or less like a lifelong follow-up, because they can get a recurrence anytime. On the other hand, if the patient gets a recurrence during this period, he gets an injection of anti-VEGF and continues his monitoring on a 4-weekly basis. Patients who are requiring injections more than 8 weekly, if they were on ranibizumab, try shifting to aflibercept. This is the second group of patients. They don't get dry after 3 months. There's still some fluid. But over the next 3 months, you see that the fluid is neither increasing nor decreasing. It's become stable. The vision is stable. These patients can then be considered for a treat and extend regime. You can increase the extension from, again, by 2 weeks till you come to 12 weeks with ranibizumab or 16 weeks with aflibercept. The important thing is that today we are giving a lot of patients initial loading doses of aflibercept. So if you're giving an initial loading dose of aflibercept and the patient did not become dry after 3 injections, then you can consider trying a treat and extend regime for them and seeing what is the maximum you are able to achieve. If you're not able to get greater than 8-week extension, you may even go back to ranibizumab. Now, the reason for this is because I believe that in Asian patients, we've seen much more geographic atrophy in patients who are on aflibercept. So if possible, if the choice is between aflibercept and ranibizumab with the same interval, I would prefer to give ranibizumab. So this is what it is. If you gave 3 injections of aflibercept, patient became dry, you can continue this patient on a treat and extend ranibizumab, and if you can extend that to 8 weeks, 10 weeks, 12 weeks, continue on that. On the other hand, if you're not able to do this extension, you will need to go back to aflibercept and maintain on aflibercept. The third situation can be that even on aflibercept, the patient keeps on requiring an injection every 7-8 weeks. These patients would need to be given a trial of brolucizumab. The point is, if you need aflibercept and ranibizumab both 4 to 6 weekly, then it's better to be on ranibizumab than to be on aflibercept. So basically, we want to have the patient on as long a follow-up as possible. What about patients who have not responded to Eylea? Now, this is a patient who was on month after month of Eylea, was not responding, and we decided to switch this patient to brolucizumab. And he responded very well with the resolution, in fact, within a week of the RPE detachment and the SRF. 1 month later, I did not want to repeat brolucizumab because there were reports coming in of more reaction being reported in patients who were getting brolucizumab on a monthly basis. So we gave him an aflibercept at that point to increase this gap. And the patient maintained 3 months after that, and he's now got another injection. On the other hand, this was a patient who was, again, no response to aflibercept, but intraretinal cysts, just not responding, was finally given a brolucizumab, did not get as great a response, did not respond till 1 week, but by 4 weeks there was a decrease in these cysts, and we again covered up with Eylea before we gave the next injection 4 weeks later. Even in this 4 weeks, the patient got an increase in the intraretinal cysts. So how do you decide when to switch? To my mind, if the frequency of injections with ranibizumab is every 7 weeks or less, I would consider shifting these patients to aflibercept. If the patient is on aflibercept and is requiring an injection every 7 weeks or so, I would again consider giving an injection of brolucizumab. In a patient who's stable, not dry, is requiring monthly ranibizumab, that's not good enough, shift to aflibercept. And if the patient is stable on aflibercept, but is requiring even 6 weekly injections, consider a switch to brolucizumab. However, after telling all this, what becomes critical is how important is the injection you give. And I was amazed by this study, which had a long-term follow-up of 3 different drugs, ranibizumab, aflibercept, and bevacizumab, and found no difference in the visual outcomes or the number of injections between the agents used. The OCT showed decreased fluid from the initial to follow-up visit, whether it was subretinal or intraretinal, more or less the same, no difference between the agents used. What did make a difference was the more the number of injections given, the more the time the injections were continued, the better the visual outcome. So ladies and gentlemen, please, if your patient cannot afford aflibercept, don't say, I can't treat this patient. continue with what you have. It is more important to continue the treatment rather than make sure that you have the most expensive drug which is available. And you may still be able to maintain the vision for a large number of your patients. This was a study in which they used only ranibizumab, and at a fixed interval of 4 to 8 weeks, they maintained over 7 years pretty great results, better than 20/40 vision in around half the patients, with more than 2/3 of the patients getting 6/18 vision or so. So, ladies and gentlemen, it is possible, the last slide, it's possible to maintain these results if you continue the treatment long enough. The basic principles to keep in mind: there is no tolerance for fluid. Intraretinal fluid is not tolerated unless it's completely unresponsive. Subretinal fluid of up to 100 micron you may tolerate if it is stable and not responding further. You don't have to run after sub-RP fluid. It does not go away with ranibizumab or even aflibercept. But any increase in fluid must be treated. And the most important thing is, in active disease, follow-up every 4 weeks is critical. Ultimately, your results depend on following up the patient intensively and giving the injection when required. With this aggressive treatment, making sure you treat patients with any loss of vision, any new fluid, any new macular hemorrhage, or any subjective evidence of fluid in your mind, you are able to maintain vision for the majority of your patients. Ladies and gentlemen, eternal vigil is the price that we pay for maintaining vision in patients with CNVM. Thank you very much, ladies and gentlemen.
One comment from Dr. Nitin Verma, and then we'll close the session.
Yeah, no, I think I was very pleased to see that Avastin or bevacizumab is still on the horizon, because I personally use a lot of it for things that are not covered by government subsidies. So, but I think the lesson that we've learned from COVID is when patients haven't been able to come for treatment, and then after 3 months or 4 months or 6 months, they come back and say, well, I haven't had a treatment for 6 months, so am I cured? And I think the important thing, as you've highlighted, Dinesh, is the fact that you are never cured, and that some injections are better than no injections, and as soon as you can get back to your treatment regimen before you couldn't come or because of COVID, the better you are, because you don't know when a CNVM is going to reactivate.
Yeah, and that is why the counseling I do for my patients with ARMD, exudative ARMD is, look, you're going to get these injections for your life. Don't forget to take them. And if I cop it, take it from someone else. But continue to take your treatment.
Thank you, Dr. Dinesh.